Hey y'all, I'm Dr. Josh Elo. This is Eloge Deka. We are both psychiatrists working at Rush. Today, we're going to talk a little bit about suicidal ideation and a new paper that just came out in Journal of Clinical Psychiatry looking at nitrous oxide for suicidal ideation. So before we get started, really quickly, just want to mention this is a pretty serious topic. And so we're going to be talking a little bit about the context of what treatments we have that have some evidence. We're going to be talking about suicidality in general over the last several years and some trends and some characteristics, and then we're going to dive into this paper. So without further ado, Ani, how are you, man? It's good to see you.
Yeah, it's good to see you too, Josh. It's an important topic. It's September. It's Suicide Prevention and Awareness Month, which was interestingly started in 2008. And it's time for us to acknowledge folks who are dealing with suicidal thoughts and also connecting folks if they need any help in treatment or management of mental illness or suicidal ideation. So it's a really important topic, and I'm really excited to talk about this today. But if this is something which is not something you want to see, we want to give you the opportunity to move away from this video.
So I introduced us briefly. Like I said, I'm Dr. Josh Elo. I do some research at Rush, and then Ani is the director of transplant psychiatry and a consult liaison psychiatrist. So this is the paper, Nitrous Oxide, Reducing Suicidal Ideation, Treatment-Resistant Major Depressive Disorder. And this is an exploratory analysis. So this was published just this month, really timely for this month of suicidal awareness. But also, this is an exploratory analysis. So not a primary outcome. It's looking at people who have treatment-resistant major depression, so people who have failed some previous trials. So let's get into some more specifics about this paper. But first, let's talk a little bit about why this is important. Obviously, as Ani was mentioning, this is a really important outcome and symptom that a lot of people deal with. And it's sad to say, this is taken from the CDC. We're not doing great at reducing suicide, people who have died by suicide. You can see here over the last 20-ish years or so that the rate has continued. And this is people who have died by suicide. There was a drop off here, but I'm sad to say that the new data just came out for 2022. It hasn't really been fully published yet, but it looks like there's an uptick going back up to the peak that we saw in 2018. It's really discouraging.
It sort of
Let me go back.
highlights how things changed in 2020. I wonder if the time has something to do with the pandemic and everything that happened subsequently.
Yeah. Yeah. I mean, in 2021, 48,000 people in the US died by suicide. 12 million Americans thought about suicide, and 1.7 million attempted. This is important to kind of distinguish this because it's not all the same. Thoughts, actions, and then completed. These are how we kind of break it down. And so this paper, we'll get into it a little bit more, is really addressing the suicidal ideation, and we'll get into how they define that in a little bit. Men are 4 times more likely than women to die by suicide, and then a few racial groups. The highest suicide rates are for non-Hispanic American Indians and Native Alaskans, followed next by non-Hispanic whites. So Ani, give us a little bit of the context before we jump into the paper. Would you mind?
Yeah, of course. So before we get into paper, we really wanted to talk about what are the evidence-based treatments that we have for suicidality so far. Of course, you have the evidence-based psychotherapies, including CBT, which is cognitive behavioral therapy, and also dialectical behavioral therapy, which have been shown in different populations to help with suicidality, self-injurious behavior, things like that. But as psychopharmacologists and psychiatrists who often prescribe medications, what do we have? The one that has had the longest proof of concept and proof of evidence has actually been lithium in suicidality, particularly in bipolar disorder. But there's also been some evidence to show that perhaps lithium reduces suicidality in patients with a major depressive episode, regardless of whether it's a unipolar or a bipolar depression, independent of what the actual diagnosis is. So there was this 2006 meta-analysis of 31 studies. It was by Baldessarini, and it was looking generally at reduction of suicidality compared to treatment without lithium. So it was treatment as usual, but without lithium in patients with a depressive episode, whether it was depression or bipolar disorder, a major affective episode. They included schizoaffective disorders as well. And they found that there was an odds ratio of almost 5 times lower risk of suicide or suicidality in patients who were receiving lithium opposed to patients who were not receiving lithium. That was way back in 2006. Now, it's important to note that the definition of suicidality in all of these 31 studies varied quite a bit. What is suicidality, which is a very subjective concept? Is it a suicide attempt? Is it actual suicidal ideation? Is it that the clinician is worried there is a risk of suicide at that point due to their affective instability? So in any case, this is a meta-analysis of 31 studies. It showed us a direction that perhaps addition of lithium in major affective disorders, whether it's bipolar or unipolar or schizoaffective, may have a protective role. And that's where the thought of adding lithium comes in. It's a double-edged sword, though, right? Lithium is a double-edged sword, Josh. We do have evidence that it protects from suicide, but it's also very easy to overdose on with lithium because it's a very narrow therapeutic index. There are often patients that I see as a CL psychiatrist, I'm sure you see them too, where folks come in with lithium overdoses, and those can be very complicated and very serious. There was another study in 2021, Katz and others, where they looked in the VA population. Again, this is not a generalized population. It was in several veteran affairs hospitals, where they looked at repeated suicide-related events between lithium and placebo groups in veterans with bipolar disorder or major depressive disorder. And they found that even though there was lower suicide-related events subsequently for starting lithium or placebo, it was not statistically significant. Adding lithium may confer some benefit, but again, like anything in medicine, it's a risk-benefit analysis, and it's a conversation that you'll have to have with your patient, whether the benefit of it is enough to overshadow any risk that you may accrue from taking the lithium. For me, what I'm trying to conceptualize is lithium treats the affective illness, and we know that it treats the bipolar disorder illness very well. So if we're treating it for bipolar disorder with suicidal ideation, I wonder if that makes more sense than just trying to treat suicidality by itself without a concomitant bipolar disorder. Just an affective illness, or not even an affective illness, because 50% of the patients with suicidality may not have an affective illness. Do we just put folks with SI on lithium? Does that even make any sense?
Yeah, really interesting points here, because you're right. Like, obviously, from a DSM diagnostic perspective, suicidal ideation is a part of how we diagnose a major affective disorder in an episode. But you don't necessarily need all of that to have those thoughts, right? You don't necessarily need to be in that episode. And I'm thinking of our last video where we kind of beat up on lithium a little bit, and here we're kind of like, well, we thought it was good, but maybe it doesn't really separate with Kat's paper. So we still love you, lithium, but struggling to find it exactly your spot, maybe with this. I think it's important to bring up also that it's tough from an evidence perspective, right? Like, a lot of our clinical trials exclude folks who have suicidal ideation, like active suicidal ideation, typically with like plans and intent. And so those folks don't get into the evidence that we tend to rely on, like the kind of gold standard of these randomized controlled trials. And so then it leaves us with trying to put together more retrospective analysis, right? And so it's good because it's real life. It's, hey, this person came in, they got lithium, versus this person that came in, they didn't get lithium. Let's compare what happened with big groups of people, like what the Katz paper did. But then you worry about, well, this isn't really controlled. Is there some confounding by indication? Like your point, like lithium is kind of is easy to get toxic on. So if they're having suicidal ideation, I think they're actually going to do it. Do I put them on lithium? Because that's going to really kind of give them something to use. So there are some variants here that make it a little bit difficult from an evidence perspective to feel confident of like yes or no, not just lithium, with a lot of the treatments that we're going to talk about here.
I think it's an important point about this ability to delineate whether or not you have SI related to a psychiatric disorder or you don't, because as we're understanding, suicidality is a multifaceted phenomenon, which has flummoxed psychiatry for generations. We still don't have good understanding of what actually comes into suicidal ideation or suicidal thoughts. It's probably multifaceted: social, psychological, cultural, and of course the biological. But what percentage of contribution to each particular case of SI or suicidality, it's difficult to determine. And that's where subjectivity and clinical acumen and clinical judgment comes into play to figure out what is the best form of treatment.
Tell me about clozapine.
Yeah, so clozapine. So I recently scrolling through my social media and I saw a post about clozapine in suicidality, and the poster was making a good point about the clozapine gap. We have this clozapine gap where
Mm,
folks with treatment-resistant schizophrenia are not getting clozapine because of the rigors that is associated with prescribing clozapine and monitoring clozapine. And they talked about this evidence that we have from this really landmark trial called Intercept trial, looking at clozapine. And they, interestingly, they didn't do clozapine versus placebo. They did clozapine versus olanzapine to look at
mm.
whether or not there was reduction in SI or suicide related behaviors in these patients, and they found that there was a statistically significant reduction in suicidal behavior or suicidality if folks were on clozapine versus olanzapine. Now, keep in mind, these are patients with schizophrenia. This was not studied in bipolar disorder, depression, or just in general population. This is a very specific subset. Going back to my point, like the social media, there was like this conversation where some folks were saying that, well, clozapine is going to take a long time to work. Why not use ketamine? But again, this is for schizophrenia, right? These are folks who have psychosis, and this is what the evidence has shown. It's a chronic illness. Suicidality is a chronic risk factor. About 10% of
Hmm.
patients with schizophrenia die by suicide. It's a chronic treatment. Obviously, ketamine is a rapidly acting antidepressant, helps with suicidality in the short term, but it's not the population. Schizophrenia is not the population that ketamine was originally studied in for us to make the point that ketamine should be used in these specific patients. So important things that we want to just focus on is lithium has evidence for patients with SI in affective illness, particularly bipolar disorder. The rest of it is a little bit fuzzy. Clozapine has evidence for prevention of suicidality in patients specifically with schizophrenia.
So then, moving on, you're talking a little bit about the ketamine and esketamine, and so this is really interesting. I want to speak or make that transition a little bit. It's important to obviously talk about this in relation to the primary disorder, psychiatric disorder, if that is available. Because you're right, like if we're going to have schizophrenia, like using something like ketamine really could destabilize the psychosis, and so we have to be, although there's excitement about using something that might be a little bit different and new, we need to be careful about not destabilizing the underlying illness, which obviously a decompensated psychosis is also a risk factor for suicidality in itself. So that's really important to put that in the context with the primary disorder. So esketamine, ketamine, tell me about this, Ani.
Yeah, so this is a accumulated evidence of intranasal esketamine. So this is primarily for esketamine, which is the one that's been approved by the FDA for treatment of major depressive disorder and acute suicidal ideation. This study by Wang and others, they were able to demonstrate that compared to placebo, there was a significant reduction in the suicidality scores of whatever questionnaires they used. It's a MADRS questionnaire that they used, and there was a significant reduction in the items for suicidality in that particular questionnaire compared to placebo. And based on these studies, the FDA provided that approval for not only major depressive disorder, but also for acute suicidality for esketamine.
The indication was interesting, right? Because this is partly that we don't have great measures for assessing suicidality, right? Like we have the Columbia that lets us get to kind of active versus passive, these like traditional terms that would be used. Now, item 10 on the MADRS, it gives us a little bit like of a variation there about how bad it is. I think it's 6 different, kind of a Likert scale of how bad, but it's just like one question. It's tough, really, right? And so this is interesting because it did show benefit, but then when they went to the FDA, they actually ended up getting indication for depressive symptoms in major depressive disorder with suicidal ideation. It wasn't specifically to SI. It was to treat kind of this, what we're talking about, this cluster of SI in the context of a depressive episode. But the wording was really fascinating because it's really tricky to get an outcome measure that's really going to be as convincing as we would like it to be to get that kind of indication from the FDA.
Yeah, that's what makes it challenging. Research on suicidality, right? Like definition of suicidality confounds us still, and even to put protocols to test for reduction in suicidality is difficult. And I think that's something that this paper struggles with too, the paper that we'll discuss.
All right. SSRIs, controversial.
Oh,
Black
this is
box warning. Yeah. Yeah.
oh
So
God.
well, no, I hear the sighs. So please let it out, Ani. Tell me about it.
Yeah, so this is, I think, very well known about
Yeah.
SSRIs and suicidality. The black box warning was placed in 2004. This is a black box warning that you can see that antidepressants, again, they put in the word antidepressants, not just a class called SSRI. They just put the word
Mm,
antidepressants increases the risk of suicidal thoughts and behaviors in pediatric and young adult patients. They're essentially saying, I think, 25 or younger, up to 25 or younger. This black box warning came from a pooled meta-analysis that was done under the aegis of the FDA, where they found that there was evidence of elevated suicidality, suicidal ideation compared to placebo. Interestingly enough, there wasn't actually any difference in actual suicide attempts or completed suicides in that study. Interestingly enough, there were several studies that were done after this black box warning came in, which really dissuaded a lot of primary care docs and pediatricians from prescribing SSRIs and antidepressants.
hmm
It shouldn't be surprising, but to some people, it is surprising that most of mental health treatment, especially pharmacological mental health treatment, occurs in the primary care setting instead of seeing a psychiatrist. So,
Yeah.
after this black box warning came out, the rates of prescribing antidepressants plummeted. There was actually a trend of increasing diagnoses of depression in the primary care setting and resultant prescribing of medications to treat appropriate treatment of depression in the pediatric population until 2004. And then the black box warning comes out. There was a plummeting of even diagnosis of depressive disorders. So what does that tell you? It tells you that there was consternation, fear, whatever you call it, amongst primary care physicians or pediatricians to diagnose it right there at that setting, because if you diagnose it, you got to treat it. And then you are placed in that situation where you have to go through that black box warning and everything that comes with it. So it's a bit of an unfortunate issue that started happening. There were also further studies that were done, which also showed that in the second year after the warnings, antidepressant use reduced by 31% amongst adolescents, 24% among young adults, and 14% among adults. And there was also a relative increase parallelly to overdoses, psychotropic drug overdoses. While antidepressant use decreased, there was increase in
hmm
overdoses in adolescents and in young adults by about 21% in adolescents and 33% in young adults. So telling us that perhaps at that point, with reduction in treatment of depression with SSRIs, you started having an elevation of suicide attempts, especially overdoses. This is an important topic which we don't have a
Yeah.
full answer to yet, but I think we need to put this black box warning in context, that this was a pooled meta-analysis. There are many methodological flaws there. Subsequently, we started finding that there was a reduction in diagnosed depressive cases, which shouldn't be the case. You should have a steady rates of diagnosis or maybe higher rates of diagnosis if you're having better mental health care. But for a sudden reduction of diagnosis after the labeling of SSRIs is concerning. And even more concerning is this elevation in the rates of overdoses after the black box warning and resultant decrease in treatment of depressive symptoms. So this is just like something that we want to talk about. This is a controversial topic. We understand people might have different opinions about it, but I think we just wanted to talk about the evidence and put it into perspective so that people are aware of the risks and benefits of SSRIs and any resultant suicidality. One last thing I wanted to talk about SSRIs is that in the same analysis that FDA based their recommendation on, there was no increase in suicidality in adults. And secondly, there was in fact a protective factor which was seen in patients over 65 years of age. So that black box warning really does not apply to folks who are adults beyond age of 25 years, and especially in folks who are older than 65 years of age. So to have a blanket statement that SSRIs can induce suicidality is something that we should be cautious about making such statements.
Yeah, I mean, a great job kind of pulling all that apart. And I think it's really to see these associations, not necessarily causation, but it is worrisome. And I'm glad that more data has become available to make us realize like we do need to think about these antidepressants for young folks because, there is something protective here that's really important. And obviously this outcome is a really serious one. So yeah, I think this is well stated. Thanks for putting this together. Continuing on with the black box, this is interesting because as Ani said, the black box warning in the SSRI says antidepressants can. And so it's become this class effect, which if you think of it from like a neuroscience biologic perspective is somewhat ludicrous because if you're modulating serotonin, if we think that is how antidepressants work, that's for another discussion. And then you start something else like esketamine or ketamine that doesn't really act in the serotonin system or really any monoamines, works pretty separately, but we say that they have the same risks. I don't know, that's a bit of a leap in my mind. I think a little bit about maybe the motivations for keeping that black box in because, this is risky and we do not want this outcome, right? And so maybe warning like, hey, make sure that you're thinking at least about this and talking about this with your patients. I can see where maybe we get there, but it is important because, Ami and I were talking about the trepidation with prescribing when you have somebody in front of you who has depression or the risk of potentially destabilizing the illness or causing SI, kind of in what you're talking about with adolescents and young adults, it makes me worried about not treating perhaps the greatest risk factor for SI for a fear of that outcome, right? And so it's a little bit of a chicken and egg situation. So I think it's important to mention like this black box warning, ketamine, as we see here over on the left, has been out forever, right? It's been generic for a long time, used it a lot in anesthesia. It's now become a treatment that we've used in psychiatry a lot. Not this is, off-label. FDA hasn't approved it for anything in psychiatry. But then we go to esketamine, the Bravado, the S enantiomer of the racemic mixture of ketamine that was studied in depression and, as Ani was mentioning, treatment-resistant depression, MDSI, this somewhat SI indication. And then suddenly we have this new black box warning where ketamine, which arguably is very much the same, and then this new indication causes new black box warnings when in fact we have this MDSI, but also watch out for suicidality. It's like, okay, I guess we can worry about both, but it is kind of confusing. It makes me think a little bit about this recent indication for Rexulti and like the black box warning of mortality in elderly, but also go ahead and use it for agitation in Alzheimer's disease. It feels like speaking a little bit out of both sides of the mouth. And I think I can't help but wonder about clinicians feeling confused about, well, okay, what do I do with this? Where am I supposed to go from here?
Yeah, I think I agree with you. It's an important topic to highlight and make people aware because we don't want that risk, because that's really the biggest risk. It's the primary psychiatric emergency that we have, suicidal ideation, right? But also when we have the FDA putting in labels such as this for esketamine, for like this slide shows, for suicidal thoughts and behaviors, a black box warning, whereas for ketamine hydrochloride, which is essentially just a mixture of R and S, ketamine, and there is no mention of suicidality, it sort of makes me think that a lot of this is not quite evidence-based. This is fine for trying to warn people, but the problem is when you put it on a black box warning, that becomes, whether you like it or not, a part of evidence, right? It becomes an evidence. People will quote it in their scientific literature. People will quote it when they're discussing a medication. So just by being a black box warning, it itself becomes an evidence, even though we don't know where this evidence comes from. And I assume this evidence is just being carried over from that original meta-analysis of primarily SSRIs, which is a completely different mechanism of action than ketamine. And that's just being carried over because this is being marketed or approved as an antidepressant. So I think these are issues that need further clarification from the FDA so that clinicians are more comfortable in prescription of these medications. And also patients are able to access these medications and also understand appropriately the correct risk factors instead of extrapolation of risk factors from a completely different class of medications. I don't think we're doing any service if we're extrapolating from one type of medication to the other, which is completely unrelated.
Yeah. Yeah, and I think you're right. Like I'd be curious to see if it does end up inhibiting access, which obviously, as we highlighted earlier, is we have an urgent need to have some agents for SI and to be trying to stabilize this uptrend. Okay, so our paper for today. I'm excited about this paper. One, it's new, it's timely, as I was mentioning before, published in the Journal of Clinical Psychiatry just this month. And it was a quick report, just like a page or two. And so it's really easy to digest and go through. So to set the stage about nitrous oxide is that stuff that you have gotten at the dentist, perhaps. Laughing gas is another name for it. When we think about esketamine and how it works in terms of blocking the NMDA receptor, it has some other effects too, but that's kind of the primary one that we think about with that medicine. And it having this unique ability to address suicidality, it's made the field think about like, okay, there's something about glutamate, which interacts with the NMDA receptor. There's something about this. How else can we hit that receptor in interesting ways? And lo and behold, nitrous oxide is an antagonist at the NMDA receptor. And it's thought that this is how it's useful for kind of like a mild anesthetic. But what if we're able to use it for psychiatric purposes? So psychiatry is taking stuff from anesthesia, we're taking stuff from dentistry. I'm curious to see what we'll take from podiatry next. So in this study, it was exploratory analysis. There was some clinical trials looking at nitrous oxide for treatment-resistant major depressive disorder. So this is poor response to 3 antidepressants, lifetime, and in the current episode, so this is going to be like recurrent major depressive disorder, a failure of 1, at least 1. And that's how they define TRMD. They had these trials running, and then this is an exploratory analysis. So they took folks who had a certain level of suicidal ideation and pulled them out and said, okay, in this specific population, could we see something interesting here? And so when they pulled those folks out, they found 13 folks who had suicidal ideation that were randomized to the nitrous oxide arm, and then 17 who were randomized to placebo. And so that kind of became the cohort for this study. Again, not the primary outcome. SI is not the primary outcome in this. This is a exploratory analysis based on these previous trials. So the SI that they defined, this gets back to our previous discussion about how do you define this in a way that's meaningful clinically, but also meaningful from like a statistical perspective to be able to see some sort of difference. And, with all the things we highlighted, the concerns about having a good measure, they used what they had. And so they used the Hamilton as opposed to the Madras or the Columbia or the Sheehan suicide tracking. And they looked at the Sheehan has essentially 4 levels. It has 0, no suicidal ideation. 1, which is life is not worth living. 2, which is having like thoughts that they wish that they were dead. 3, which is actual suicidal ideation or gestures. And then 4, which is attempts at suicide. So somewhat analogous to how we think about the Columbia, for those of you who use this in your clinical practice. And so in this study, they said 1 and 0, not quite enough. 4, that's too severe. Let's exclude those. So we're really looking at 2 and 3, folks who had 2 and 3 at randomization before they went forward with this trial. Now we'll just mention one more thing. There's a crossover design. So this was looking at folks to get placebo either first or second, and then later to get nitrous oxide or placebo first, and then the converse later, but blinded to which one they were going to get. And that's the way they set this one up. So everybody ended up getting nitrous oxide. It's just a crossover design. So it was dependent on did they get it first relative to placebo or second.
And just wanted to add that with the definition of reduction of SI, how they measured reduction of SI, they looked at a 2-point reduction in that item 3 of the Hamilton, reducing from 3 to 1 or from 2 to 0. That's what they look for to call it a significant reduction.
So what did they find? So they administered the placebo or the nitrous oxide, and then they asked in 2 hours. They did the Hamilton again to see where it was at. And then they did it 24 hours post-dose. There wasn't a change in the suicidality, not statistically significant at 2 hours, but at 24 hours, they found that 54% who had nitrous, the active group, had a meaningful reduction, the definition that Ani just mentioned of drop of 2 in suicidality. 54%. Remember, this is treatment resistant, right? And then in the placebo arm, only 2 had a meaningful, 2 of the 17, so 12% had a meaningful reduction in the suicidality. And, to this bigger question that we've been talking about through here is SI in the context of what disorder? So this is SI in the context of treatment resistant major depressive disorder. And they found that the SI improved, but the depression also improved in those folks, like this corresponded. And so in this analysis, it wasn't only SI, like that got better, but the depression remained. Kind of the whole disorder, as long as we think about SI as part of depression, the whole thing kind of got better with the treatment.
Yeah, so like Josh mentioned earlier, this is an exploratory analysis of 3 previous randomized controlled trials where they actually looked at just depression, treatment-resistant depression, and they had positive results for rapid antidepressant action for for those trials, they did this exploratory analysis where they pulled the data from those 3 previous analyses to look at SI. And interestingly enough, they are having a similar rapid reduction of SI in 24 hours as well.
I like this heat map here.
Yeah.
So on the left, essentially, because this is relatively small, so you can kind of get into the nitty gritty a little bit of who specifically responded. And so looking at the left side, this is the active arm with the 13 participants, and essentially every row is a different participant, and the different colors are the severity of the score on that item 3 of the Hamilton. And so you see that there were folks who, up at the top with the darker red, that was 3, that was the more severe suicidal ideation or gestures. Those folks responded, 3 of them did. And then even in the folks who had more of this somewhat passive wishes that they were dead, they also responded. So it wasn't really like only the severe were the ones that responded or the more mild. Like it seemed like, again, this is small. This is, we're small takeaways, but it seemed to be relatively equally distributed in regards to baseline severity, which I think is interesting to see that can be applicable in different clinical variations in terms of severity.
Really fascinating results. And I agree. I love that heat map. It makes it so easy to grasp the concept.
Yeah, we want blue. Blue. So as I was just alluding to, this is really small. There's a crossover design. So crossover designs are cool in that you get to like decrease some variability that maybe you didn't randomize well for, in terms of like people in the placebo arm are different somehow than the people in the active arm. In a crossover design, you get to compare relative to the same individual, which is kind of nice. But there is a fear about the crossover design in terms of lag of the effects, right? And so this study, there was a bit of variability about when they could get the active treatment versus the placebo treatment. And so this question of like, if nitrous oxide is good at 24 hours, but maybe it lasts for several weeks, those effects. But then you get randomized to the other arm or the crossover design. Is there a little bit of carryover here? That's something to be considerate of when we think about these results.
I do want to say that with this carryover effect, actually, when you do have a very strong carryover effect, it tends to favor the null hypothesis, essentially going away from the observational analysis. So for example, if you got nitrous oxide first, and then you had a carryover effect of nitrous oxide, a positive carryover effect of nitrous oxide, and then 2 weeks later or 3 weeks later, you receive the placebo. So that actually goes in favor of this study. If you do have a carryover effect due to utilization of nitrous oxide previous to the placebo, then the effect that you're seeing is a little bit muted than it would have been if you did not have the carryover effect. So it's not necessarily a negative, but it is something that we should be aware of. And I think the authors did do in their previous trials, not this pooled analysis, in their previous trials, they looked at the folks who received nitrous oxide first versus folks who received placebo first. And the carryover effect tended to be more significant in folks who received nitrous oxide first, meaning that carryover of the antidepressant effect of first receiving nitrous oxide was more important than first receiving placebo. And then you probably didn't have a more significant carryover beneficial effect. So it's a limitation of the study from the data perspective, but it actually perhaps points towards these positive results being muted than they actually are.
That's interesting. Yeah, I like that perspective. I mean, with the small study and not being an RCT, like it definitely is a hypothesis generating exploratory analysis. And I think the hypothesis is, hey, we should look at this some more. So there's enough movement here to garner some interest for, I hope that the authors continue and others look to recruit some more folks to see if this really can be reliable. Because, like to the second point here, like rapidly acting antidepressants are exciting. They're where the field is going, and they are needed, especially when you're in this like suicidal crisis syndrome state. You're just feeling trapped. You're feeling like you're hopeless. You don't have any options. Like that's a place where we need some stuff to work quickly for obvious reasons. I think, this is a question about maintaining durability in the response. This is a question really that comes from some of the other rapid acting antidepressants like an Esketamine or Spravato. The risk of the recurrence of the depressive episode is just so high when folks are responders and then they stopped for whatever reason. The risk of recurrence is really high. And it's like a lot of our treatments, we end end up treating the acute phase, but then people stay on the medicines for decreasing the risk of future episodes. So same things with nitrous oxide. If we're going to have a one-time dose, get folks feeling less suicidal, get them hopefully feeling better, and then what's next? Do they continue to get these? This brings up an interesting point about, risks in terms of nitrous oxide has been associated with decreases in vitamin B12 concentration, leads to increases in methylmalonic acid because it can have these neurologic effects, right? And so if we end up needing to use this treatment more frequently, figuring out how we're going to best support folks from a B12 deficiency, as well as other things that we need to examine, is going to be an important caveat and something for us to figure out with the ends up coming into guidelines at some point. And then mechanistically, this is where the fun is about like the biology and the specifics. Is the NMDA receptor antagonism the best available target for SI? Is there something specific about that lining up with this treatment? No, I think, I think this is a really interesting point. And we've been so excited about glutamate system and its relationship with GABA for sure, but the glutamate system and how it interacts with the NMDA receptor for a long time in psychiatry, really, but especially in mood disorders. And so to be able to have some targets here specifically for that system outside of the monoamines, which we've been using for like 60 years now, and just kind of getting a lot of Me Too drugs without a whole lot of difference in terms of its mechanism of action or its efficacy, to go outside of that and then to be able to get into this other system with the glutamate and GABA, it's really exciting, especially if there is a signal here. There has been demonstrating a signal of it going after, this thing that's flummoxed us forever about suicidality. So at this point, given what we know, which is not enough, frankly, about the brain in depression and suicidality, from what we know now, this does seem really, really important to target, or, as more therapies come out that specifically are going after this system.
And so far, the proof of that has been the positive trials and subsequent approvals of Esketamine, and more recently, Auvelity, which contains dextromethorphan, which is again a NMDA receptor antagonist. To Josh's point, I think the NMDA receptor and just the glutamate system is really fascinating because there are many downstream effects to NMDA receptor antagonism, which not only causes changes in the glutamate GABA balance and causes glutamate surge, there may also be further downstream effects in number one, even the monoamine system, which is the traditional system that we've always used. And secondly, it can also have the further, even more downstream effects on BDNF and neuroplasticity. So this might actually be a neat common receptor which has downstream effects in various pathways. And that's why perhaps we're seeing this rapid antidepressant effect compared to other single pathway treatments like SSRIs, which are just focusing on a specific monoamine.
I mean, Ani, you're preaching to the choir here, because yes, it all gets down to BDNF. And so while the SSRIs certainly give us more serotonin in the synapse, like that doesn't correlate with the improvement in the symptoms, right? It really is a downstream sort of thing. And that's what these rapidly acting antidepressants are showing, is that it's not really the monoamines for a lot of folks. It actually is a neurotrophic brain growth mechanism by which we think, I'm open to being wrong, but for now we think that this is going to be an important player for depression. And think about this, where ultimately BDNF shows up with these SSRIs. Ultimately, BDNF is what is getting stimulated via glutamate, NMDA receptors. Like that is kind of a neurotrophic effect as well. Lithium giving us BDNF. Oh, suicidality. We talked about that one earlier. And then, one treatment that we failed to bring in here, I'm just recognizing now, is ECT. ECT stimulates BDNF, is effective for acute suicidality. I mean, an NMDA receptor antagonism is an important player in this part, but when you get all the way there, it ultimately does come down to neuronal growth, which can be mediated by, BDNF is like the poster child for that, but there's a lot of factors here that are able to influence the neuronal growth and the synaptic budding that comes along with that.
The BDNF and the synaptic growth, the neurogenesis, synaptic plasticity is so important because now we have further new treatments that are in the pipeline, including other psychedelics. The mechanism of action is through neuronal plasticity, improved neuronal plasticity. So the BDNF seems to be a major pathway molecule towards getting you that neuronal plasticity. The ultimate goal of treatment seems to be, so far in the new era of psychiatry, psychiatry that we're having is to get that neuronal growth, neuronal plasticity, connectivity changes in the brain. I think that's what we're looking at. And we have for a very long time, I think it's been our fault as psychiatrists of not having educated other physicians and the general public about how far ago we had actually moved away from the monoamine hypothesis, right? Even with SSRIs, yes, they cause changes. SSRIs and SNRIs causes changes in the monoamines, but that's not the mechanism. It's not a chemical imbalance hypothesis the way it's sort of put forth. And I think as psychiatrists, it was easy for us to explain it that way, right? It's easy to explain it as a chemical imbalance in your brain, but really the effect of these medications, now we're more and more understanding that these are downstream. These are actually related to neuronal growth and the neuronal plasticity more than anything else to treat a lot of these illnesses that we are dealing with.
I think it's a matter of it's what we knew when we knew it. We were pretty sure it was chemical imbalance in terms of monoamines, and the neuroscience revolution happened and is happening. And we know more now, right? And so we can replace some of that language about a chemical imbalance with this neurotrophic theory of depression, where it's actually about neurons being able to make connections with other neurons. And that is maybe the way by which depression actually gets better. To your point, like that language, it can be replaced and it can really be brought to the bedside. And that's what's particularly exciting about these new treatments is it highlights, oh, this is what we think is happening. And is there a way that I could talk to my patient about this kind of complex neurochemistry in a way that helps them understand what's going on with their illness? Because especially when it comes down to suicidality, when folks are feeling hopeless and they're feeling like there's no chance of anything happening, being able to give some hope is so important. And if you can pair that hope with your treatments and how you think it's going to work kind of differently based on what you know about how it works, and let the patient kind of get it a bit at whatever level they're able to grasp this, that's where it really can get exciting and really hopeful. And you can help that patient realize that there are options. We think about this a little bit differently than maybe what we have been thinking about over the last several decades.
Yeah, no, absolutely. I think just wanted to mention that suicide is a multifaceted phenomenon, suicidal behavior, suicidal ideation. We're talking about one aspect of it, one facet of it, which is the biological that we can help patients with. But there are other conversations in other fields of medicine and sociology that are equally important, and we need to be able to integrate all of these things, the biological, the social, the cultural, and the psychological, to get the best care that we can for our patients. But I think what we have as psychiatrists, I think these are what we talked about today are very important elements to push that movement forward. At least we can add some strength to the improvement of those biological factors, or addressing those biological factors and the neurological factors that we are aware of. But I think other aspects of suicidal ideation, depression are equally important, and we should continue to put efforts as a society towards them so that we can get the best care, the best results that we can for our patients. These are really important conversations to have, not just in September, which is the Suicide Awareness and Prevention Month, but also across the year all the time. We should have these conversations in an ongoing basis.
Yeah. Good point. Ani, pleasure as always. That was a really great discussion. Yeah, I'm looking forward to our next one.
Yeah, likewise. Thank you everyone for joining us. Bye-bye.
Bye-bye.